In this presentation, the techniques for the intramedullary fixation of a diaphyseal femoral fracture, AO classification 32ABC, will be demonstrated using the femoral Recon nail or FRN system. Upon completion of this exercise, you should be able to state the clinical indications and contraindications, describe the correct patient positioning, prepare for the insertion of the nail, identify the entry point, and perform the key surgical steps for the insertion and removal of the implant. The FRN with standard locking is indicated for fractures in the femoral shaft. AO fracture classification types 3 to A, B, and C, excepting subtrochanteric fractures. The FRN with Recon locking is indicated for fractures in the femoral shaft in combination with femoral neck fractures. AO classification types 3 to A, B, and C, combined with type 3-1B. Subtrochanteric fractures. AO fracture classification types 3 to A, B, and C, 1.1 to 3.1. The patient is positioned in the lateral decubitus or supine position on a fracture table or radiolucent operating table. The image intensifier is positioned so as to allow visualization of the proximal femur in both the AP and lateral planes. To insert the guide wire, the instruments used in this exercise are the guide wire, diameter 3.2 mm, length 400 mm, the handle, with quick coupling, the protection sleeve, diameter 14 mm, the multi-hole drill sleeve, diameter 14 3.2 mm, and the universal chuck with T-handle. The handle, protection sleeve, and multi-hole drill sleeve are assembled. The assembly is positioned at the insertion point. Alternatively, the guide wire can be inserted without the protection sleeve and multi-hole drill sleeve. The wire placement is confirmed in both the AP and lateral planes. The wire is inserted to a depth of approximately 15 centimeters. If the first guide wire was positioned incorrectly, a second guide wire can be inserted at an offset distance of 5 mm from the central hole by using one of the other holes in the multi-hole drill sleeve. To facilitate the insertion of a second guide wire, the drill sleeve can also be rotated in 90-degree steps. After the second guide wire has been positioned correctly, the first guide wire is removed. To prepare for nail insertion, the instruments used in this exercise are the handle with quick coupling, the protection sleeve, diameter 14 mm, the drill bit, diameter 14 mm, cannulated, flexible for quick coupling for DHS-DCS, the 2.5 mm reaming rod with ball tip and extension, 950 mm, the universal chuck with T-handle, the depth gauge for nails, the elongation tube for reaming rods for use with the depth gauge for nails, the protection tube for medullary reamers, diameter 14-12 mm, the trocar for protection tube, diameter 12-4.6 mm, the flexible shaft, the rod pusher for reaming rod with hexagonal screwdriver, diameter 8.0 mm, the Synream reamer heads, and the holding forceps for reaming rods. While holding the protection sleeve in place, the drill bit, diameter 14 mm, cannulated, is used to drill over the guide wire or reaming rod until the stop on the drill bit reaches the protection sleeve. The progress of the drill is monitored regularly with the image intensifier. Ensure that the lateral and medial cortical walls are not compromised. The guide wire can be adjusted if necessary. After the medullary canal has been opened, the guide wire, protection sleeve and drill bit are removed. The 2.5 mm reaming rod with ball tip and extension 950 mm is inserted. The reaming rod insertion depth is confirmed under image intensification, taking account of any possible distraction at the fracture site. The depth gauge and elongation tube are passed over the reaming rod down to the nail entry point. The nail length is read directly from the measuring device. If necessary, the femoral canal can be enlarged to the intended diameter with the medullary reamer. The reamer protection tube, trocar, and protection sleeve assembly is inserted over the reaming rod, sliding the trocar and reamer protection tube into the bone. The trocar is removed from the assembly and, starting with the 8.5 mm diameter reaming head, sequential reaming is performed in 0.5 mm increments up to a diameter of 0.5 to 1.5 mm greater than the nail diameter. The rod pusher can be used to help retain the reaming rod during reamer extraction. For nail insertion, the instruments used in this exercise are the insertion handle, radiolucent, femoral Recon nail, the cannulated connecting screw, the screwdriver, hexagonal, diameter 8.0 mm with T-handle with spherical head, length 322 mm, the driving cap with thread for insertion handle, the combined hammer 500 grams, the combination wrench, diameter 11.0 mm, and the pin wrench, diameter 4.5 mm, length 120 mm. The screwdriver, hexagonal, diameter 8.0 mm with spherical head, is assembled to the cannulated connecting screw by inserting the tip of the screwdriver until it clicks into the recess of the connecting screw. The geometry of the insertion handle is matched to the nail by aligning the arrow on the nail with the line on the barrel of the insertion handle, and then connecting the nail to the insertion handle. The nail will click in and self-retain. The connecting screw is passed through the insertion handle and securely tightened with the screwdriver, hexagonal, with spherical head. The hexagonal screwdriver is then removed. With greater trochanter entry point nails, the nail is inserted manually over the reaming rod into the femoral opening, with the insertion handle oriented anteriorly until the nail reaches the isthmus. As the nail is advanced past the isthmus, the handle is rotated so that it is positioned laterally for final seating. The insertion handle must not be struck directly with the combined hammer. If the hammer is used, the driving cap is threaded into the insertion handle. As gentle blows with the hammer are applied, image intensification is used to monitor the tip of the nail. Once the nail has been seated, the driving cap is removed. The grooves on the insertion handle facilitate visualization of the nail position. The most distal groove represents the proximal end of the nail. The 5 mm distance between the subsequent grooves on the insertion handle correspond to the supplemental extension provided by the end caps. The 2.5 mm reaming rod is removed. The entry point for the nail is in line with the medullary canal in the AP and lateral views. The point is posterior in the proximal femur, in the piriformis fossa, but varies with patient anatomy. If reconstruction locking is intended, the entry point in the piriformis fossa must be selected so as to allow the Recon screws to be placed in the center of the femoral head. The handle, protection sleeve and multi-hole drill sleeve are assembled. The assembly is positioned at the insertion point. While holding the protection sleeve in place, the drill bit, diameter 14 mm, cannulated, is used to drill over the 3.2 mm guide wire or reaming rod until the stop on the drill bit reaches the protection sleeve. After the medullary canal has been opened, the protection sleeve and drill bit are removed. With piriformis fossa entry point nails, the insertion handle is oriented laterally during insertion. The nail is inserted manually as far as possible. The insertion assembly is used to manipulate the nail across the fracture until it is at or below the level of the top of the greater trochanter. If a reaming rod has been used, it should not be removed before the nail has crossed the fracture site. The appropriate aiming arm is mounted to the insertion handle. The aiming arm is engraved with piriformis fossa, identifying the entry point that corresponds to the chosen nail. The FRN offers 3 proximal locking options. Standard locking involves an antegrade locking hole angled to 135 degrees and proximal locking using a transverse locking slot that allows for static and dynamic locking. Recon locking involves proximal locking using 2 Recon screws. Recon locking with a transverse locking screw involves 2 Recon screws combined with 1 transverse locking screw inserted in the static position of the locking slot. Standard locking involves proximal locking using a transverse locking slot that allows for static and dynamic locking options and an antegrade locking hole angled to 140 degrees for greater trochanter nails and 135 degrees for piriformis fossa nails. In this exercise, static locking will be demonstrated using the static position of the transverse locking slot in combination with the antegrade locking hole. For proximal standard locking, the instruments used are the aiming arm, radiolucent for greater trochanter, femoral Recon nail, the protection sleeve, 11.0, 8.0, length 188 mm, the drill sleeve, 8.0, 4.2, the trocar, diameter 4.2 mm, the drill bit, diameter 4.2 mm, calibrated, length 340 mm, 3-flute for quick coupling, the depth gauge for locking screws to 100 mm for intramedullary nails, the screwdriver star drive T25 self-holding, length 319 mm, the guide wire, diameter 3.2 mm, length 400 mm, and the screwdriver star drive T40 with spherical head, cannulated, length 277 mm. After confirming that the nail remains securely connected to the insertion handle, the appropriate aiming arm is mounted to the insertion handle. The aiming arm is engraved with greater trochanter, identifying the entry point that corresponds to the chosen nail. The 3-part trocar combination is inserted through the desired hole in the aiming arm and is advanced to the bone. The trocar is then removed. The drill sleeve is pressed firmly to the lateral cortex and the drill bit is used to drill through both cortices until the tip of the drill bit just penetrates the far cortex. The drill sleeve is pressed firmly to the lateral cortex and the measurement is read from the calibrations on the drill bit at the back of the drill sleeve. This measurement corresponds to the appropriate length for the locking screw. The drill bit and drill sleeve are removed. As an alternative, the depth gauge for locking screws can be used to determine the locking screw length. The measuring device is inserted through the protection sleeve, making sure that the hook grasps the far cortex. The measurement is read from the back of the protection sleeve, which indicates the appropriate length for the locking screw. The screwdriver star drive T25 is used to insert the appropriate 5.0 mm locking screw through the protection sleeve. The groove on the screwdriver provides a visual indication that the locking screw is fully inserted through the sleeve. The tip of the locking screw should not project more than 4 mm beyond the far cortex. These steps will be repeated if the second antegrade locking screw is to be inserted. The three-part trocar combination is inserted through the aiming arm and is advanced to the bone. The trocar is then removed. The drill bit is used to drill through both cortices until the tip of the drill bit just penetrates the far cortex. The depth gauge for locking screws can be used to determine the locking screw length. The measuring device is inserted through the protection sleeve, making sure that the hook grasps the far cortex. The measurement is read from the back of the protection sleeve, which indicates the appropriate length for the locking screw. The screwdriver star drive T25 is used to insert the appropriate 5.0 mm locking screw through the protection sleeve. The protection sleeves and the aiming arm are removed. Recon locking involves proximal locking using 2 Recon screws. If the use of Recon locking is planned, it is recommended to perform proximal locking prior to distal locking. Furthermore, the antegrade locking hole cannot be used in combination with Recon screws. For proximal Recon locking, the instruments used in this exercise are the aiming arm, radiolucent for greater trochanter, femoral Recon nail, 2 protection sleeves, 11.5, 8.5 for LFN reconstruction locking, 2 drill sleeves, 8.5, 3.2, 2 trocars, diameter 3.2 mm, 2 guide wires, diameter 3.2 mm, length 400 mm, the reamer, diameter 4.5, 6.5 mm, length 484 mm for hip screws LFN, the fixation sleeve for use with reamer, diameter 4.5, 6.5 mm, the direct measuring device for guide wires, diameter 3.2 mm, length 400 mm, and the screwdriver star drive T25 self-holding, length 440 mm. After confirming that the nail remains securely connected to the insertion handle, the appropriate aiming arm is mounted to the insertion handle. The aiming arm is engraved with greater trochanter, identifying the entry point that corresponds to the chosen nail. As an option, the aiming device for AP orientation is inserted into the 2 holes on the anterior side of the aiming arm and locked in place using the connecting screw. The image intensifier is positioned for an AP image. It is rotated until any of the orientation lines is on the center of the inferior Recon hole. This line will represent the trajectory of the guide wire. A 3.2 mm guide wire can be inserted into the corresponding hole in the insertion handle to predict the location of the Recon screws. The cam lock lever must be in the unlocked position. Both 3-part trocar combinations are assembled and inserted through the desired Recon holes in the aiming arm. The inferior trocar is then removed. The superior trocar is removed. The inferior guide wire is inserted into the femoral head, approximately 5 mm from the subchondral bone. The guide wire placement is checked radiographically in both the AP and lateral planes. The second, superior guide wire is inserted into the femoral head. Again, the guide wire placement is checked in both the AP and lateral planes. The drill sleeve is removed and the direct measuring device is inserted over the guide wire into the protection sleeve and advanced to the bone. The length of the Recon screw is read directly from the measuring device. The measuring device and the inferior guide wire are removed. The reamer is guided through the protection sleeve to the bone. The drill stop is attached to the reamer at the appropriate screw length. The previously measured length for the screw is set on the reamer by fixing the drill stop in the corresponding position. The correct length is read from the side of the fixation sleeve pointing towards the tip of the reamer. The reamer is drilled to the stop. The fixed fixation sleeve prevents further drilling. Using the screwdriver Star Drive T25, the appropriate Recon screw is inserted through the protection sleeve into the femoral head. A groove on the screwdriver indicates when the Recon screw has been fully inserted. The drill sleeve is removed and the steps of measuring, drilling, and insertion are repeated for the second, superior Recon screw. End cap insertion is an optional procedure. End caps fulfill two functions: preventing bone ingrowth into the nail and extending the nail if it has been over-inserted. The end caps are cannulated for use over a guide wire if necessary. The instruments used are the screwdriver, hexagonal, diameter 8.0 mm with T-handle with spherical head, length 322 mm. The screwdriver Star Drive T40 with spherical head, cannulated, length 277 mm, and the guide wire, diameter 3.2 mm, length 400 mm. The screwdriver, hexagonal, diameter 8.0 mm with spherical head, is used to remove the connecting screw, and the insertion handle is removed from the nail by pulling the handle away from the nail. A 3.2 mm guide wire is inserted into the proximal end of the nail. The screwdriver, Star Drive T40 with spherical head, cannulated, is used to thread the end cap into the nail with clockwise turns until fully inserted and tightened. The guide wire and screwdriver are removed. Implant removal is an optional procedure. The instruments used in this exercise are the screwdriver star drive T40 with spherical head, cannulated, length 277 mm, the guide wire, diameter 3.2 mm, length 400 mm, the screwdriver star drive T25 self-holding, length 319 mm, the pin wrench, diameter 4.5 mm, length 120 mm, the combination wrench, diameter 11.0 mm, the extraction screw for tibial and femoral nails, the hammer guide, and the combined hammer 500 grams. The guide wire is inserted for easy alignment of the screwdriver into the cannulated end cap. Using the T40 screwdriver, the end cap is removed. Using the T25 star drive screwdriver, remove all but one of the locking screws, leaving a proximal locking screw or Recon screw in place. Before removing the final locking screw, the extraction screw is threaded into the nail. The locking screw will prevent nail rotation as the extraction screw is tightened. The hammer guide is attached to the extraction screw. And both are tightened using the combination wrench. The remaining locking screw is removed with the screwdriver star drive T25. The nail is extracted with gentle blows from the combined hammer. You should now be able to state the clinical indications and contraindications, describe the correct patient positioning, prepare for the insertion of the nail, identify the entry point, and perform the key surgical steps for the insertion and removal of the implant.